Yeah, so perhaps the bigger question is they're twofold. One is, are there any biomarker-driven approaches for patients with DNA repair deficiencies or HHR deficiencies? And the second one is related to the timing of when you actually find that or identify that patient. So let me tell you that the NCCN guidelines have drastically changed how we think of genomic testing in men with prostate cancer. We have evolved quite drastically for the last 5 years, and I think it's fair to say that any man with a family history of a genetic syndrome should actually undergo genetic tests. I think the importance of defining genetic testing is what kind of genetic testing do we really talking about? One could be somatic, which is basically identifying DNA changes in your tumor, if you will, or mutational changes in your tumor. And the other one is germline testing, which really relates to what genomic changes do you have since birth or conception that are passed on from, if you will, from your parents. So if you look at the incidence of DNA repair deficiencies from birth, i.e. germline mutations, that's actually around probably less than 10% with the best data that we have in North America, published from the Seattle group many years ago, and it's still consistent with new series published at ASCO GU this year. If you look at the presence of DNA repair deficiencies and or HHR deficiencies also in somatic, specifically, meaning not from birth, you probably will capture around 20% of patients or so. So really about a third of our prostate cancer patients will be, if you will, biomarker identified and therefore potential candidates for a PARP inhibitor. I think the biggest question when you look at that is how do you test these patients? So if you look at the NCCN guidelines, again, patients with a family history of genetic syndrome, then we'll put them at a risk for prostate cancer. Those patients do deserve genetic testing and meetings with genetic counseling. Any patient with high risk localized disease also actually needs to undergo genomic testing, and any patient with metastatic prostate cancer should also undergo testing. So if you really summarize this, I would argue that the vast majority of our patients with advanced prostate cancer, and some specifically with localized high-risk features and young age, should actually undergo genetic testing. We may find more than DNA repair deficiencies of the HHR changes, but the reality of it, the actionable biomarkers that we have right now would only entice for us to use a PARP inhibitor for those selected patients with a DNA repair deficiency. So I would like to summarize by stating that in the community practice, when you see a patient with advanced disease, every patient should actually undergo testing. Now, the use of a PARP inhibitor, where you use rucaparib or olaparib, the two PARP inhibitors now FDA approved in prostate cancer, really is tricky and controversial because right now the existing data actually suggests that the use of these agents should be for people in the castration-resistant space with DNA repair and or HHR findings. However, the utility or the use of these PARP inhibitors on the ideal patient population early in the natural history of their disease remains. Also, the use of PARP inhibitors, although quite enticing for us because it's the first biomarker-driven approach ever developed for prostate cancer, it is short-lived and it's not quite durable for most patients. And lastly, not all DNA repair deficiencies are the same. Clearly, the bulk of the data that we have really relates to BRCA1 and BRCA2. But when you look at other DNA repair deficiencies and or HHRs, the true use of PARP inhibitors and therefore their effectiveness remains questionable at best.